speakers for this morning. So in remembrance of Dr. Shrikant Kulkarni, MS General Surgery, India, I call upon Dr. Shrikant Kulkarni, KBR Technical Fellow Diagnostic and Prognostic Groups, USA, to give a talk on restore renal function by ureteral decellularization in chronic kidney disease. Dr. Shrikant Kulkarni presents affiliated with Vanderbilt University and holds the position of KBR Technical Fellow and Research Scientist. So,
thank you.
Good morning, everyone. Thank you for the opportunity to present the work by my father, because he passed away a couple of months back, and I'll be presenting what he was working on. So I don't have a medical background, so if I'm wrong at some point of time, please bear with me and you can correct me that. So what he is going to present was work on unilateral decellularization in chronic kidney failures, and that's the work what he has been continuing to work on. To start with, kidney storage, there is a very shortage of kidney donor organs, and for the past 20 years there is a lot of being pushed to look into how organs could be donated, but there is a big gap which has been going on, and for that there has been effort into manufacturing bioengineered organs, for example kidneys, and how to improve renal function and quality of life. Even due to a lot of transplant which has been done, patients are still desperate because there is due to drug toxicity and also complications which arises due to transplant which are happening. And there are several biological advances which have been done, and stem cell research is a strategy to reconstruct this totally disruptive kidney bioengineering, which is still out of reach of many patients, and how do we bring that to the patient as close as possible. To look into that, there is work which has been done on tissue and organ failures, which is one of the biggest health issues as part of the whole paradigm in our society. There is also, as I mentioned, there is a deficiency, or the ratio between the donors and the patients is increasing over a period of time. How do we decrease that, or how do we come up with different methods which can help us to define or cure the patients? One way to look into that is whole organ decellularization and recellularization, which has attracted a lot of work, and there has been a lot of research done in this area. And this talk will be based on that work, where we are looking into different methods, how these methods will be useful in reconstructing your kidney in situ. There are different alternative options, treatment options which are there, but the ultimate goal is to use clinical therapy for disease regression and restore the function in spite of a very limited number of cells or reserve cells, and also mechanism to repair this damaged renal tissues, which will be replaced by a fibrous tissue. Though there is a disparity between the treatment provided and the treatment given in CKD, we are looking into how we can improve on making sure that that gap is reduced as much as possible. Going forward, renal oxygenation in pathophysiology of CKD progression has received a lot of interest, as we talked about it. But CKD is a silent disease that most patients are unaware of till they actually go to the doctor, and the doctor itself, when they have a lot of challenges because they are not able to diagnose this very early in their life. If it's diagnosed early, then that makes it possible for them to introduce this treatment and cure the patient at the earliest possible. It's also characterized by progressive loss of renal microstructure or microvascularization, which leads to local hypoxia, and the probiotic response and scarring of the deterioration of the renal function that leads to the damage of the kidney. So if you look into this updating or looking into curing it at a local level, if you are able to detect it early, the local hypoxia as well as any damage due to the diameter reduction of the and the tuberosity, basically what is the microvascular network, if you are able to detect that earlier, you are able to give the treatment as early as possible to the patient. And again, there is imbalance between the oxygen delivery and consumption because of that local hypoxia which happens. The main target, what we are looking into, is to oxygenate the hypoxic tissue with two methods. One is to improve the interstitial blood supply, and the next one is to provide adequate oxygenation to the hypoxic tissue. And the net effect is looking into how do you heal and then regenerate it. So the first step is to heal the tissue which has that local hypoxia, and then try to regenerate the tissue. With that introduction, we'll go in the brief background of what different methods have been done and try to look into what the current state of art is. So kidney is basically, it has a significant number of nephrons, and there's fibrosis often progresses silently, as we mentioned earlier, which leads to overt manifestation. And chronic internal hypoxia and microvascular obliteration plays an important role in the pathogenesis or scaling of the loss and the loss of function. So you have the scarring of the tissue, and that scarring of the tissue leads to the loss of function of the operation of the kidney. Human body is always, it's known to have a very complex machine, and it remains a mystery over the years, because how in case of a scarring of a local tissues also, how is it able to recover itself. So that recovery, how can we reinvent that as part of whenever you have a failure in some part of the organ, are we able to do that locally to the kidney, or kidney in this example, but to other tissues as well. So that's the logical approach, where we are trying to restore renal structure and function by arresting a microvascular drop through an interstitial capillary network. And the other part is how to regenerate this diseased kidney through intervention and keeping the nephrons. So whatever useful nephrons are there in the kidney, how do you reuse those nephrons and then try to recover the kidney back to its original functions. In case of regenerative medicine, in stem cell therapy, there has been it has failed as a definitive therapy because of renal fibrosis, which is the root cause of the renal failure. And renal fibrosis, if it's not detected earlier, as earlier mentioned, that may then keep on degrading the system or the kidney, and it may not come to a recovery stage. So having it earlier in the stage life, that's very important for it. And vasculature, as we mentioned, is core for survival and the function of every organ. So it's not just the kidney, but vasculature is applied to any other organ in the body. And especially for renal vascularization, it has a profound effect on how regeneration happens after injury. So if you have a local injury within the organ, how does vascularization basically helps to recover that organ. So you have a minimum vascularization in the body that keeps you helps you recover it at a faster rate. Going to the another additional points where we look at dysfunction and failure, these are the major effects which happen. But the key point here is vascularization alone is not very much sufficient. You need to restore the kidney function. You need to look into how the kidney could be regenerated. What are the underlying diseases in the process that could be eliminated, and also how do you use the sufficient amount of nephrons which are present and use them for scaffolding. So scaffolding is one of the key ways for regeneration, and we'll talk about that where we decellularize and then cellularize the organ in stepwise. But as part of the conventional treatment approach, it does not reverse the fibrosis, so diseases continue to progress at the end stage, which is fatal. So what happens is, in the conventional approaches, whenever we try to use the fibrosis of a disease or any other organ, if it progresses till the very last end, then probably the recovery or the reversal of that process is very difficult. So detecting it earlier and then trying to reverse that fibrosis in the earlier stages of any organ is vital for curing the patient. As an additional background, the first kidney transplant was done in 1954, and that was between two twins, and that was a successful kidney transplantation which was done. And this was very important because this used for the first time the least or without any immunosuppressive medical therapy what was used, and that's the reason that this was done at the Peter Brent Brigham Hospital, and that's the reference for the work. But the best option for kidney transplant is there, but it's a temporary solution. It's not a permanent solution because the patient, once they have the transplant, they lose their graft due to, again, the fibrosis, because whenever you have a connection done between the arteries, you have that interstitial fibrosis which is happening. Despite that, one says, and a lot of techniques also due to the immunosuppressive drugs, there is a 40% recipients succumb to the death because of not the organ not being accepted, or due to loose grafts which happen over the period of several years. And the patient themselves, though they recover, they are not able to live a full life because they are always on immunosuppressive drugs. They have limited capability to move around. So is there another way, or can we do this a method, or there is a method to recover it within using the same body structure or the body organ of the patient itself? And that's where regenerative medicine comes into picture. What's the current methodology? We'll look into the decellularization technique, what we talk about. So that is basically removal of cellular components from an organ and preserving the micro and the macro anatomy of the extracellular matrix. So you keep the organ as is, but you remove the micro and the macro anatomy out of it. And then the basic requirements is to do a cellularity and the functionality, keeping it as consistent as possible with the ECM, which is the extracellular matrices. So you are keeping the structure of the organ as is, but then you are removing the damaged components or the damaged cellulars out of it. And then decellularization is basically, it's a versatile natural biomaterial scaffold, which is basically used as a base component for rebuilding the tissue and the organs back to it. So you are removing the damaged tissue, and then you are putting back the new updated tissue or the transplant tissue from the donor, or it could be from the self organ itself. And then preserving the micro environment for future regeneration is very important. We need to look into the functional biomaterial, which is the base material for this, and also natural scaffold, which is same as the physical and the biochemical function, so which is the DCM. So that is the gold scaffold because it's within the same organ itself. So the probability of rejecting that organ is very low in that case. And that's why it's called a gold scaffold, because you are using the same healthy tissue in another in a decellularized matrix. In case of the cellular, in case of the cellular microenvironment, we are not defined or limited by specific genes, but we are more defined by the healthy environment what is around. We need to put into ourself into the right intercellular microenvironment, and that could prevent the aging or the aging of the organ or the disease. And again, progressive downhill disease which affects cellular environment, because if the environment itself is not healthy enough, then even if you have a good scaffold, you have a good recellularization, if the environment is not good enough to support the system, you have a progressive downhill, and that damages the organ as you go in the life of the patient basically. So that's why modifying the environment to simulate autonomous regenerative process is very much required. It needs to look into lab support new organ inside a body to regenerate. So instead of doing a transplant from a lab support organ, doing a regeneration within the body using the same scaffold or the same cells of the patient itself, which are from the healthy side of the organ, that is very important. And environment, again, that's the biggest factor, because that helps to understand what diseases or what other diseases may be affecting the patient in this case. What is defective microcirculation? So best bioreactor for tissues and organ from humans are being used. So stem cells, they are the body's raw material, so that's used as a raw material, and any defective or microcirculation universal pathological features, we try to remove them. Right? If you know what are these defective microcirculation environments, how do you remove them or try to remove them out of the system? And again, there remains an imbalance which exists between the treatment and what treatment the patient requires, and also the loss of valuable time. And the valuable time is basically when the patient reaches to the doctor or the advisor, and at what point of time they reach the doctor, or what point they are able to provide the medical facility to the patient. So it's a very symbiotic treatment. The patient should be taking care of themselves, but then in addition to that, what is the treatment provided by the doctor or the medical supervision under which they are being treated for. So these all depend on both from the patient side as well as from the treatment care given by the doctors. What are the different methods for decellularization? So chemical methods currently are being used, and these are some of the examples. What we see are from the lab test. So these are from one of the cadavers. Once the decellularization is done, you see that it's affecting the organ. And what it does is it's a physical method where the whole protocol we are trying to save time, cost, and quality. So the material which is used, there are different ways which can be done. This can be done through. So, but how to do it or what is a very specific way to do it, that's very important. And there are a few examples what we have been, what are shown in this work. So this is for a actual human, one of the propine cadaver, which is from the lab, and then this is one of the cadavers from the actually a human kidney. So this shows that it's very important that the way decellularization methods are implemented, that's the key, and using a specific protocol and not to damage the organ itself is key to this. How does the host tissue respond to any of these scaffolding? So when you do this decellularization, how does the host tissue or the host organ respond to this? So the efficacy of the decellularization and removal of cell remnants, it depends on how much the reconstruction or what type of technique is used and how much decellularization is done. So if you do it for the whole organ itself, will the organ be able to sustain that? Or if you look into partial part of the organ, then in that case probably the organ is able to recover itself completely. But if it's 3/4 or more than 3/4 of the organ which has been damaged, then how does it recover? So there are different ways in which you can look at it, and that depends on what vascular network is there in the organ itself, and also mainly the ultrastructure, the underlying structure of the organ. Biomaterials which are formed by humans and organ tissues, they are used for removal of any of the immunologic cellular components. And the scaffolding material, what is used, is believed to be used, has a lot of potential for this tissue regeneration. So keeping the structure itself intact and not damaging the structure, that has a lot of potential for regeneration. And as decellularized DCM has shown success in scaffolding. So that is the reason one of the ways or this method is moving towards decellularization of DCM, because there is a lot of potential through research which has been done in recent years. What is the method for doing this? Now we looked at the background of what is cellularization, what is decellularization, how do you try to get it to work, what are the different methods used, what is the cost between that, what are the pros and cons, but how do we do decellularization? And there are one of the ways what has been proposed in this work is through hydrostatic pressure, and that's the hydrostatic pressure for the kidney, where we are looking into physical decellularization into producing a uniform effect throughout the tissue, which is more effective. So doing not changing it from different places, but uniformly enlarging the tissue and then scaffolding it back to its or folding it back in even pressure, under even pressure. That's very important. And hydrostatic pressure has proved to do that, and that's one of the methods what has been proposed. It's naturally derived from biomaterials, so it's superior to artificial polymers because it's done within in situ in the body of the patient itself. There are other novel deceleration methods which are used. So there are some mechanical properties of the decellularized tissues which is not altered. So what we are trying to do is there is not to alter any of the internal material of the organ itself. And how do you reduce the inflammation? So these are the two deceleration methods are trying to use these techniques. So what they do is if you use any of the hydrostatic pressure methods, the mechanical properties are kept as is, and also you are trying to reduce the inflammation, because then if you have inflammation itself, then the organ needs to work towards how to keep it healthy under inflammatory conditions. So try to reduce the inflammation, but then try to also do this deceleration. So there are these, it's a pro and con, so we have to be very careful on how that is done. And what under deceleration techniques, what is easily to retain is the structure of the ECM and the physical form of the organs of the tissue. So keeping that constant helps a lot. And once we have done deceleration, the next step is basically to recellularize the scaffold with the patient's own cells, which are the healthy cells of the patient. So you are removing the damaged cells and then recellularizing them with the patient's healthy cells. There is a lot of uncertainty because of the viability, functionality, and efficiency, and also the uniformity of the organ after grafting. So even though the organ is the same, there is always a lot of uncertainty around it based on how healthy the tissue is, what is the efficiency of the existing tissue, though it's a healthy tissue, is it still healthy enough to recover itself? And then this difficulty of complexity of scaffold that challenges on introducing cells to different parts of the scaffold. So if you have, based on the availability of the scaffold what is there, do you recellularize the whole scaffold, or do you recellularize it in different patches? That's also another method which has been used. The whole organ reproduction is difficult, and that's what I talked about, that you have to do it in parts, so not doing it for the whole organ, because you have to keep some organ within the healthy organ as part of it, and only try to descaffold the unhealthy part of it, or the fibrotic part of it. For repopulation of human-sized kidneys, around 150 million of epithelial cells are required, and hundreds of billions of kidney epithelials are needed. So for the KEC and the EC, these are the numbers. So if we are around these numbers, there is a chance of using recellularization to bring back the degraded organ. And also low concentration of why we need at least these number of cells, because low concentration of cells they may cause a poor seeding efficacy, because if you have a poor seeding in these scaffolds, then your recovery rate is going to go low, and that's where your uncertainty comes into picture, where if your seeding itself is not good enough, how will you be able to recover that the organ? And also high concentration of cells that may result in the cell death and or vascular blockage. So not going higher also is not a good way of doing it, because then that may lead to damaging of the cells itself, because they will keep on having issues with vascular blockage part of it. Going forward, in situ regeneration, it takes advantage of the recipient's body regenerative capabilities. It's able to purify DCM, provides natural environment for DCM, because that's the decellularization. There has been work done for ECM of mammalian organs and tissues using as substitutes for scaffolds to restore. So the earlier picture, what we saw in one of the earlier slides, there was the Procine, which is the lab animals which are being used. So there is a way in which you can use mammalian scaffold or mammalian organs for doing this scaffolding restore. And an actual ECM scaffold, it provides a good physical and biochemical environment around it. And finally, there is abundance of discarded human kidneys, but they are not useful for transplant, because there is availability of organs, but then due to certain conditions or certain requirements, they are not able to be used. Lab testing on animals and fibrosis is produced within a very short period of time, but for humans, the disease takes a long time to develop or degrade the organ itself. And so that's why even if you have a combination of mammals and humans, there is a certain amount of gap which is there, because the way in which the disease will progress in certain animals, it may be different from mammals or humans basically, and the way at which it degrades the organs, though the organs are the same, there will be the way they degrade would be different. So these are some of the things what we need to also look into and have it for comparison. And tissue specific DCM, it's becoming more feasible option coming up, and also there is a good potential for ideal scaffolding to be used. So that's the way, or that's the method going forward. So with this current way of looking in the what are the different methods being used. So what I talked about was the different methods what are being used, and now we'll go in the mid section where we'll talk about the proposed methodology. And here we'll talk about so first part is to look into the kidney blood supply. So kidneys are hypoxia despite plentiful of blood supply, but due to the loss of the pertibial capabilities which is caused by fibrosis, it decreases the blood perfusion. So this is just to show that which parts of the kidneys are capable of providing the blood supply, because you have rich amount of blood which is going through the kidneys, but the arteries which are the direct branches of the renal artery that goes to the cortex and the supplies of the renal capsule. And if you have cortical renal fiber, so yes, so if you have a I'm not sure how that works, but if you have any cortical renal fibrosis, these gets contract and that leads to ischemia. So that's in the upper part in the center where you see the renal artery. If you have any of these renal fibrosis, that basically leads to compression, and the ischemia is formed at that local level. And this mechanism leads to new blood level formation. So what we are trying to do is trying to restrict the amount of blood which is flowing, generate that ischemia, and which receives massive attention, and that would then lead to regeneration of the more tissues. To create these new tissues, defective renal microcirculation is a universal pathological feature in CKD, and to restore blood vessels is very key. So because kidney filters out almost like 30 times a day, which absorbs 95% of the urine which is provided. So 1 to 2 liters of urine which is provided done by the kidney. So restricting that part that leads or the renal artery, that will lead to regeneration of the blood vessels. And how does that is done at the nephron level? So regulation of the renal oxygen is a novel therapeutic target, because hypoxia is main cause for CKD. The need for better understanding of hypoxia or ischemia and development of novel intervention and strategy is to do the elimination of fibrosis. So if there is a fibrosis which is produced, then you have it locally generated, basically on the specific nephrons for the cortex, and so you see the first part is the whole kidney, and then you have the renal pyramid, and then each nephron is getting affected. So this would then try to affect the regulation of the renal oxygen. Basically, you're trying to attack each of the nephrons within the kidney itself. This needs a good understanding of how hypoxia or ischemia is developed, and how the intervention and the different strategies to eliminate fibrosis. So it is done in 2 stages. So in the early stages of CKD, we ignore where restoration of the function is possible, and failure is due to lack of understanding of the origin of the vascular damage. So if we are in the early stages, what we talked about, that if we are in the very early stages, if you are not able to detect it, then probably we are not able to, if the understanding is not there of how the kidney is going to be damaged or degrading, then the lack of understanding will not be able to get the good diagnosis for it. So where the actual vascular damage is happening. And there have been several animal models which have been studied, and those are not directly faithful. So they are within 80 to 100% of the accuracy of the actual human models what are present. An application of deceleration techniques. So in this method, what we are trying to do is then apply a pressure material to the patient's urine, basically to route to deliver of a device in the ureter. So I'll talk about that in the next slides, in a few slides, where how we are trying to block the ureter and then try to use the urine as part of doing the stretching and the relaxation technique. To stop the draining of the urine flow and collect it in the pelvis of the kidney, that would create artificial hydronephrosis. And this work of this deceleration technique had been presented in some of the earlier papers what he had presented. So you can always go and read to those papers and refer to that work also. And I'll be happy to share the slides for that work. Due to the increased luminal hydrostatic pressure, that can lead to forced deceleration through the fibrotic tissue and drive the cell residue out of the ECM. So if you have a fibrotic tissue and you are putting a pressure on the tissue, that tissue will start to expand, and that would release any pressure what is there on the tissue, and it starts to break out. And that is where you are trying to remove the fibrosis out of the damaged part. It provides a wide contact area because it's the part of the whole kidney, the best removal of the fibrotic cells, and also doing fibroblasts and excessive any of the collagen tissues which are present. So that excess pressure will try to remove everything out of it and try to break it down. And the reason for this is providing a sterile, clean, natural scaffold with vascular network. So since this is in situ, there is no external entity or an external organ which is trying to be attached to it. It's a very good environment, and also it has a lot of vascular network which are part of the organ itself. So this is the method what has been proposed. So you have your ureter, you have your fibrosis which is on the top, and this is the whole renal capsule. So there's an artificial block which is provided, and so in the day one you have some urine which is collected, and over the period of time urine gets collected, and that creates starts to increase the fibrosis, or it starts to increase the structure. And this will lead to stretching of the fibrosis due to the pressure. That's what we talked about, and we are trying to break that fibrosis using the same pressure. And once that pressure at a certain point, you keep on observing the patient and trying to see how much pressure is developed. So based on the pressure development, you can do that through different methods, where you can actually check the patient every day or every couple of days to look at how the pressure has been increasing. And once that pressure has increased to a certain level, then that expands the fibrosis, and then you suddenly release the pressure out. Once you release the pressure, that collapses the fibrosis, and then that leads to removing the fibrosis part what is present. So what we talked about it is how to decellularize it basically. So this is how the decellularization process would take place. So this method is one of the ways wherein you are actually just trying to keep the pressure inside the kidney itself, not having being attached to any other external parts of the body, or not affecting the patient in any way. So the patient can still continue to do his daily activities, but we are trying to keep them under a good observation. So with that, in the final conclusion, what we have is how can we make this happen? So biological system has got a good potential to regenerate. So this is the first step of innovation, and we must try to find a solution. Biological system has got several ways in which we can regenerate. So cellulation and decellulation is one of the ways of doing it. Early you treat the fibrosis, we get better tissue. So that's exactly what we talked about. If you have an organ donor, one organ donor saves almost 8 lives because you have different organs being used by other patients. But a lab-grown organ, if the probability of failure is high, so theoretically it saves 0 lives. So how do you try to use an alternative method for innovative applications of cell biology and regenerative medicine? And this revascularization is sufficient to restore the kidney function of a diseased kidney. So that itself is a good way of a method to restore your kidney. So not using any other way of doing or using any bio or artificial lab kidney. So just using revascularization should be good enough. This is the quickest way to attack renal fibrosis is in the direct action. Basically, that's in situ and eliminate any other fibrosis, and that's what we saw in the schematic or the cartoon what we saw. do not try to replace nature, and let nature takes its own care, because that's how it happens in our whole body. If you get wounded anywhere, you are cured by yourself. Your body tries to cure yourself. So how can you use that environment or proper environment to regenerate your own cells within the body? Again, creation of artificial organs has been a good way. It's taking it has gone a long way since it started, but it's still far away from target. Bio or lab kidneys, they are short-term effects, or they are short-term solutions for dialysis, but long-term impairment for living kidneys. So still, using a regenerative way of doing it is the best way to do it. And the concept is widely discussed, but is minimally researched, and this is one of the ways we are trying to present it in front of the researchers. So probably you can take it forward from here based on the what has been done. And finally, this is the last slide. So in situ regeneration utilizes its own resources. So you are using your own resources, you are using your own body to regenerate yourself. This is a novel treatment which is based on human organ regeneration in the human care. It has a lot of therapeutic implementation to correct the chronic ischemic environment, because you are trying to keep the environment as sterile as possible, because it's within your own body. So there is a good chance of keeping the environment in the most healthy state. Kidney is one of the organs in our whole body which ranks highly in its ability to repair itself. So there is a good chance of using this method to repair kidney and try to eliminate any through elimination of renal fibrosis, and then try to simulate regeneration through non-invasive techniques. So this is a completely non-invasive technique, as we talked about. And in case of children or young adults, they have the capability to restore themselves. So if you have young adults who are going through this process, there's no need to do a transplant, but using these methods would be one of the most effective ways of to giving them a better immune system in their future life. So with that, thank you so much. I really appreciate listening to my talk, and hope I did not go wrong anywhere.
Thank you so much. That was very interesting. So thank you very much for that. Next, I take the immense pleasure inviting Dr. Naguib Abdul Rahim, University Hospital Sharjah UAE, to facilitate